Here's a Puerto Rico medical revalidation style question on atrial fibrillation, AFib, with a clinical vignette based on your description. Clinical vignette, atrial fibrillation, initial management. A 68-year-old man with no significant past medical history presents to the emergency department after returning from an international trip. He reports that for the past 6 hours, he has felt an irregular fluttering sensation in his chest, describing it as a bird flapping inside. He denies chest pain or syncope, but he feels fatigued and short of breath. Vital signs show HR 130 BPM and irregular rhythm. ECG confirms atrial fibrillation without ST changes. What is the next best step in management? Direct pulmonary vein ablation. B. Start amiodarone and metoprolol. C. Schedule elective left atrial appendage occlusion. D. Immediate electrical cardioversion without anticoagulation consideration. Correct answer, B. Start amiodarone and metoprolol. Explanation. This patient is presenting with acute symptomatic atrial fibrillation, most likely new onset or paroxysmal due to travel stress. The initial management focuses on 1. Rate or rhythm control. Amiodarone, rhythm control, especially in recent onset. Beta blocker, metoprolol, for rate control. 2. Stroke risk stratification. Calculate CADS2-VASc score. Consider anticoagulation if 1. Men or 2. Women. 3. Cardioversion. Can be considered if symptoms 48 hours or if TE excludes thrombus. Why not the others? A. Pulmonary vein ablation, reserved for refractory or recurrent cases, not responsive to medical therapy, not first line in acute new onset. C. Left atrial appendage occlusion, used in chronic AF patients who cannot tolerate anticoagulation, not in acute episodes. D. Immediate electrical cardioversion without anticoagulation. Not safe unless duration 48 hours or TE rules out thrombus, otherwise risk of stroke is high. Key clinical takeaway. First episode of symptomatic AFib, rate or rhythm control plus stroke risk assessment, plus consider anticoagulation.